Good morning, good afternoon, good evening. I'm Suri Moon. I co-direct the Global Health Center here at the Graduate Institute of Geneva. I'm very delighted to be welcoming you today to the latest in our Open Global Health event series. Today we'll be focusing on the question of the role of public and private actors and responsibilities in COVID-19 with a specific focus on the Gates Foundation. I'm very delighted that we have with us today Dr. Chris Elias from the Foundation, whom I will introduce in just a moment. Before I do that, just a couple of words about the Open Global Health series and the topic of today's webinar. So the Open Global Health series is our flagship series for us here at the center. It's really core to our 5-year strategy. We would like the series to open up debate on important issues in global health, especially those that have to do with power, politics, and governance, which is the central focus of our center. And when we were conceiving of this series over a year ago, one of the first topics that was brought to our attention that many people would love to spend more time discussing in an open and a frank way was indeed the role of foundations in the governance of global health, and the Gates Foundation in particular. In the interest of transparency, I would like to state that the Global Health Center is a recipient of funding from the Bill and Melinda Gates Foundation, as are many other actors in global health. And indeed, this is one of the characterizations or one of the traits that has sometimes contributed to what the New York Times has called the Bill chill, or sometimes perhaps not as much space to discuss some of the key questions around governance as we would like. In that same article in November 2020, the New York Times described the Gates Foundation as the most powerful and provocative private player in global health. The foundation has been in existence for about 2 decades, over which time it has invested about $55 billion. And over the last few years, its annual spending is about $5 billion per year. This was prior to COVID. I think about 2 billion roughly on global health, which has been roughly the size of the WHO annual budget. So clearly a big player. And entire books have been written about foundations in global health in general, the Gates Foundation in particular. Today, what we'd like to do is to focus specifically on the COVID-19 response to explore broader themes around public and private roles and responsibilities. Just a couple words on why we chose this particular theme to frame our discussion today. If we think about public actors, by which we generally are talking about governments, public actors have constituents, taxpayers, voters, usually structured and complex decision-making processes, accountability processes, etc. In COVID-19, however, governments have often had to look inward first. They've had to get their own house in order, and many governments have shown little appetite to think or look beyond their own borders and to consider the global needs and to consider the importance of international cooperation. If we contrast public actors with private actors, especially foundations, have their own resources that are often quite significant, internal decision-making processes, and it's not always clear what are the arrangements for public accountability. But at the same time, they bring tremendous resources to bear on problems that are often starved for resources, including in global health, and they can often move very quickly. And we've seen in this pandemic and in any emergency, speed is of the essence. It's both necessary and an asset. And in some ways, perhaps ironically, because foundations do not have voters, they have not had to look necessarily internally only at what's going on in their own countries, but have also been able perhaps to look externally and look globally in a way that many governments have been slow to do. So without further ado, I'm really delighted to have with us today Dr. Chris Elias, who is the president of the Global Development Division of the Bill and Melinda Gates Foundation. This division is responsible for a number of major programmatic areas, including emergency response, polio eradication, and vaccine delivery. He has spent at least 9 years, I believe now, at the foundation, and was previously president and CEO of PATH, one of the largest product development partnerships, which I'll come back to a little bit later. He's a medical doctor by training, and he's also a member of the Global Preparedness Monitoring Board. You can learn more about his many achievements on our website, where you have his full bio. In terms of how this event will go, I'll first turn to Chris to provide us with some introductory remarks on what the Foundation has been doing, in fact, in the COVID-19 response. After his opening remarks, we'll have a bit of a fireside chat for about 20-25 minutes, and then I'll open the floor for questions from all of you. I'll try to reserve minimum 20 minutes for Q&A with the audience, and we'll try to get through as many questions as we can in a moderated format. So without further ado, Chris, over to you. Thank you again.
Thank you, Suri. It's a pleasure to join you again for one of these seminars with the Geneva Graduate Institute. And good morning, good afternoon, good evening to colleagues around the world. Suri asked me to maybe begin by saying a little bit about what the Bill and Melinda Gates Foundation has been doing in response to COVID-19 over the past 15 months or so. And I'll do that, but first I want to frame, why the foundation is involved in global health. About a little over 20 years ago, Bill and Melinda realized that many of the diseases that were a nuisance here in the United States, but could be treated and rarely cause death, were actually significant causes of morbidity and mortality in developing countries. And that health inequity really helped to motivate them in putting together the foundation, contributing a significant amount of their wealth to the establishment of the foundation. Where, if you visit us in Seattle, you'll see as you come into the building that our mission is to, help ensure that every person has a chance at a healthy and productive life. And so the idea of equity permeates a lot of the work that we do. And as Suri said, the role of philanthropy, even a large philanthropy like the Bill and Melinda Gates Foundation, isn't sufficiently large to solve really any of the world's problems. We need to think about how we can be catalytic, take advantage of the nimbleness, the ability to respond quickly and early, which is particularly important in emergency and disaster response, and has been, I think, quite important in the COVID-19 pandemic. As well as to think about how we can partner with governments, with civil society, with UN agencies, with the private sector in order to try to address places where the markets fail, where the normal incentives for product development and access aren't working well, and where, to sometimes be able to take a longer view or higher risks than governments are willing to take themselves. So that's a bit of the framing. When we, in January of 2020, began to, notice what was happening with the emergence of a new rapidly moving respiratory pathogen, we began to move pretty quickly. We've committed over the last 15, 16 months about $1.75 billion of funding. And that's in addition to, as Suri pointed out, our usual about $5 billion a year philanthropic spend. So we didn't cut our other budgets, but rather we added, in this time of crisis, a significant amount of resources. We did that in 3 phases. Back in January of 2020, we announced $100 million of response. A lot of that focused on our work through our office in China, as well as here in Seattle. We actually committed about $5 million to the local response here in the community and the state where our headquarters is located. But most of that went also into product development and trying to catalyze some of the early measures to develop countermeasures in diagnostics, therapeutics, vaccines. In our second phase of our response, which was really about a year ago, we really brought in our country offices and our partnerships in Sub-Saharan Africa and South Asia as we saw the virus spreading into those regions. And then in the third phase of our response, which is our current phase, we're looking at both how do we build more resilient systems, how do we help to protect the essential health services that are so critical for what we've achieved to date with the Millennial Development Goals and to date through the Sustainable Development Goals. If you break it down, our 1.75 billion, we spent about 680 million in new philanthropic grants. A lot of that focused on, $156 million commitment, for instance, to Gavi's vaccine access advanced market commitment as part of COVAX. $20 million to CEPI to help, add additional vaccine candidates to the mix. $50 million together with a number of partners, including MasterCard and the Wellcome Trust, to establish the COVID-19 Therapeutics Accelerator to look for either repurposed or new treatments that could be used to treat people who were ill with COVID-19. We also committed about $750 million from our Strategic Investment Fund to enable the rapid procurement of essential medical supplies and help companies finance the production of COVID-19 products for low and middle income countries. That included a number of forgivable loans to Gavi through COVAX for their procurement of the AZ, the AstraZeneca, and the Novavax candidates through the Serum Institute of India, as well as volume guarantees to support the delivery of antigen rapid diagnostic tests for low and middle income countries. And then in addition, we had about $135 million of funding from our other programs where we saw an opportunity for things we were already doing to help support the COVID response. And that includes, work that we did with the African Medical Supplies Platform and our family planning MNCH programs. My favorite example actually of that kind of work relates to the oxygen systems. Before the pandemic, the number one cause, and still the number one cause of under 5 child mortality is pneumonia. And there was a pretty good reason to have oxygen systems in place before the pandemic. The pandemic brought into focus how essential those oxygen systems were for people with severe illness from COVID-19, which has been affecting politicians and other prominent people around the world. And so there's been a renewed interest in building the oxygen systems in lower and middle income countries, which is great because I think we can do that. And that will then hopefully become a durable asset for our SDG goals for under 5 child mortality reduction going forward out of the pandemic. So that's a kind of general overview of the kinds of things that we've been doing over the last 15, 16 months. And so maybe with that, I'll turn it back to you, Suri, so we can start our fireside chat.
Thanks a lot. I wish I had a real fire here and a cup of tea to offer you, but one day the Graduate Institute will get there. I think it's terrific to have this brief high-level overview, and indeed for many of us, $1.75 billion is a huge sum. At the same time, when we think about the scale of the spending that has been necessary, worldwide, and the amount of money that governments are pumping into their economies, the amount of money that has been mobilized for the ACT Accelerator, for example, for a number of different response efforts, it is indeed perhaps catalytic, as you were saying earlier. I wanted to start by asking you indeed about a institution in which it has been reported that the foundation played a catalytic role, which is the creation of the ACT Accelerator, the Access to COVID-19 Tools Accelerator, about 1 year ago now. And how would you describe the role of the foundation in the conceptualization, the creation of this set of arrangements that really seem to spring up overnight in many ways?
Yeah, so a couple of things I'd say about the ACT Accelerator. I think it would be giving us too much credit to say that we initiated that. I think we did participate from the beginning in the co-creation with many of the other leading organizations responding to COVID-19 of what is, I think, to be precise, not an institution. It's meant to be a collaboration, a forum for bringing together critical institutions for concerted action. And early on, the principle was that we weren't going to create a new institution. We were going to use the established institutions like Gavi, like the CEPI, the Coalition for Epidemic Preparedness Innovation, like the Global Fund to Fight AIDS, TB, and Malaria, UNITAID, the Therapeutics Accelerator that I mentioned, which Wellcome Trust and we and MasterCard and many others, including a number of individual philanthropists, have been supporting. WHO, of course, which runs the coordination hub for the ACT Accelerator. as well as the World Bank, which has made unprecedented commitments to the COVID response through its various lending windows. So and we also said this will be a temporary coordinating structure for the duration of the pandemic as it's needed. So, and the advantage I think of that was that we could leverage the governing bodies of those different institutions. Some of them are UN agencies with member state governance. Some are, have more plural governance arrangements, particularly the Global Fund and Gavi and CEPI. That gave us already established connections to the civil society, connections, which have seats on the Global Fund and Gavi board, et cetera. So we were trying to leverage the existing institutional structure, which is somewhat fragmented and somewhat, in the absence of a forum like the ACT Accelerator to bring together a coherent investment case. One of the things, for instance, I think the ACT Accelerator has achieved is to actually lay out clearly for the donor community, those who want to help, where are their needs, where are their gaps? Because, quickly back last April, May, there were significant pledging events convened by the European Commission that resulted in, many countries and other philanthropies and others making pledges to support. Some of them chose to support COVAX, the collaboration between CEPI, WHO, and Gavi on vaccine access. Some of them chose to support, the Global Fund for strengthening health systems or diagnostics access. That, in fact, one of the critical partners I forgot to mention was FIND, the Foundation for Innovative New Diagnostics, which has been critical for the diagnostics pillar. So ACT-A is really a coordinating mechanism. Within it, we had 3 pillars for diagnostics, therapeutics, and vaccines, as well as a health systems connector that the World Bank and the WHO have been helping to lead. So it was more about, instead of building a new big boat, it was more about putting together the flotilla so that we could all try to head in the same direction, leveraging the existing imperfect but well-established governing bodies of each of those different institutions that were part of the ACT Accelerator. We've been part of that really from the beginning, participating, trying to align some of our resources. For instance, the volume guarantee we did for antigen rapid diagnostic tests was something that would help to ensure that tests were available as FIND and the Global Fund led the diagnostics pillar of that work. So it's more about a mechanism for concerted action than building a new institution in the middle of a pandemic. Over.
Indeed. Thanks very much. I think this really touches on one of the key questions that's come up around the ACT Accelerator, which is, what is it exactly? Is it an organization? Clearly not. Is it a collaboration? How is it governed? Who makes decisions? And I think some of the fluidity of the governance arrangements, that fragmentation, has raised some fears or concerns, I would say. And there was a public letter that I saw that the civil society representatives in the various pillars of the ACT Accelerator issued a few weeks ago, saying that both civil society groups and a number of developing country governments in particular had felt that they had not had an adequate role, that they were not able to participate in a meaningful way in governance. And what would you say is in fact the appropriate role of governments, particularly those who are supposed to be relying on the ACT Accelerator and meeting their own citizens' needs through this initiative, versus private actors such as the foundation and others in fact solving this very, very difficult challenge of access to drugs, diagnostics, and vaccines in this pandemic?
Yeah, so first, maybe just to comment on the civil society letter. I think that was an important letter. I think it was an important message to the coordinating body of ACT-A and to the principals that we needed to do a better job of reaching out and involving and listening to civil society. I think in the beginning, as I said, we were hoping that we would leverage the established mechanisms for civil society input to some of the critical partners like Gavi and the Global Fund. But as things have evolved, I think I would agree with a lot that was in the letter about we needed to be more intentional and more regularly engaging in the discussion with civil society, particularly about some of these access issues. And there is a discussion within the ACT A coordination hub about how we strengthen that a more regular and intentional engagement with civil society. I think it was a very helpful and constructive letter that will respond, that the ACT A coordinating hub will respond in, I think, a way that will bring in more civil society voice to the ongoing discussions of ACT A. On the access issue, I think we're all frustrated that while there's been, pretty much from everywhere, a strong commitment, spoken commitment to fair and equitable access to to vaccines, diagnostics, therapeutics. We have, in some cases, seen, in many cases, seen that national decisions around what's been called vaccine nationalism has resulted in slower access to, I think it was Dr. Tedros was saying that 75% of the initial vaccines were delivered in 10 countries. Now, there is some progress, right? And COVAX recently, last week, hit 100 countries have received vaccine donations from COVAX. That's not as much as we had hoped to be at this point, or the volume per country isn't as high as we'd like. So we're working closely with CEPI and Gavi and WHO on trying to secure as much access to vaccines for that mechanism so that they can deliver to all the countries that have signed up for the COVAX initiative as quickly as possible and in as great as volume. I think they have a line of sight to at least 2 billion doses of vaccine by the end of this year. That curve is highly weighted to Q3 and 4, however. I mean, I think a lot of the frustration in Q1 and Q2 is that it's been a slow start and a slow volume. I think it will pick up. I think the access agreements that COVAX is negotiating should get us to 2 billion by the end of the year, potentially beyond that, so that the current aspiration is to try and have enough vaccine to get at least 30% of the population covered, which should be enough for the frontline health workers, the essential workers, and those at highest risk. Obviously, we'll continue to try and exceed that and get to as much vaccine access as we can. So that's been a frustration, partly because of the domestic pressures many countries have felt to keep vaccine for their own populations before they share it more broadly with the world through COVAX. So we'll continue to advocate for that and to try and negotiate through our global access agreements as much as we can to gain that access.
Yeah. I'm glad you raised that, because I do think this has been, of course, an issue of huge concern. It's in the headlines daily around the world. And I think that probably the issue of vaccine access is the one on which I've seen the most positive but also critical media coverage of the foundation over the last year. And on the positive side, I think great recognition of the dedication of the foundation to global access, when many other actors, including the US government, were saying, we completely disengage with any kind of global cooperation in 2020. Certainly the amount of funding and the enabling of rapid scaling up of production, for example, by the Serum Institute, a number of contributions that the foundation has made in order to try to expand access, despite indeed the fact that governments can decide at the end of the day not to export or to hoard doses, as it were. But when we turn to some of the more critical media coverage, I think most of it centers around two themes. One is intellectual property and the foundation's overall approach or philosophy towards intellectual property. And closely related to that is a perception that the foundation is often very closely aligned with multinational pharmaceutical companies, not necessarily to the benefit of global access. And I think in particular, one of the lightning rod stories, I would say, is around the decision of Oxford University to give an exclusive license to its vaccine technology to AstraZeneca. Has been reported that that was upon the encouragement of Bill Gates. Now, from what I can glean, Oxford is not a grantee, or at least not a large-scale recipient of grants from the foundation. So I had two questions in that regard. One, is it fair to say that the foundation influenced that decision that Oxford made? And in retrospect, given all of the production shortages and challenges that we're seeing today, the worldwide shortages of vaccines, do you think that that decision on the part of Oxford was the right one?
So let me address that one first. There's a whole set of issues that you've laid out. With Oxford, and this goes back to my experience when I was CEO at PATH. Universities are critical in finding new, innovations and proving them, if you will, prove the concept of the vaccine. Um, it, you know, no university is positioned to start making billions of doses of vaccine to meet the very high regulatory standards of biological quality assurance so almost every, I think in my experience of 20 plus years, every case where a university has found a new innovation, they have to have a partnership with pharma to get to scale. I think look at the struggles we're seeing, even some of the leading pharmaceutical companies have in producing enough vaccine of good quality at the rate that we needed for this pandemic. So I think there were a number of organizations, including the Gates Foundation, that had discussions with Oxford, and did discuss the importance of aligning with a multinational company in order to ensure that they could bring their innovation to scale and benefit humanity. We were not part of the individual licensing agreement, so I'd have to defer to Oxford in terms of we weren't part of those negotiations between them and AstraZeneca. In general, if I go to your broader point, I would say we're not so much aligned with the multinational companies as we are partnering with them, because we think in most cases you need to harness the scientific expertise, particularly the at-scale manufacturing capabilities of the pharmaceutical industry if you're going to deliver public goods at scale for the lower and middle income countries. So we partner with a myriad of biotech, medical device, pharmaceutical diagnostics companies, not so much to align with them, actually to partner with them. And in each of our, one of our strong principles is when we bring philanthropic capital to help either de-risk or subsidize or underwrite research and development costs, we don't do that for-profit entities in a charitable way. We do that in return for commitments that we call global access. And this will get to your intellectual property point in that global access, in our view, is driven by our commitment to health equity. And this is where you can't, in my view and my experience, there's not one formula here. You have to look at this particular problem, the particular technology, what it's going to take to get it to be affordable, high quality, and scale production for low and middle income countries. And depending on the technology, you have to do different things. So to get to your broader intellectual property point, the way I think about intellectual property is that often that gets conflated or equated with patents. Patents are an important part of intellectual property, but so are access to critical ingredients. That could be an adjuvant, which is in global shortage, many of the adjuvants. It could be, as we're scaling up production, things as simple as medical glass. Some of the ingredients, the things you need to actually produce a high quality vaccine that passes regulatory muster can be in shortage. So you need to, a part of being able to produce at scale is securing the critical ingredients, managing the patents if they are the obstacle, but most importantly, the technology transfer that will actually allow someone, I think about a patent as kind of a recipe. I have lots of books of recipes. I'm a terrible cook, right? So you need to know how to cook. And vaccines in particular often involve fermentation. It's like baking or brewing. And so, and just to give you one example from my experience when I was at PATH, 20 years ago, the Bill and Melinda Gates Foundation made one of its first large investments, a $70 million investment to PATH and the WHO to produce a low-cost, high-quality meningitis A vaccine for the meningitis belt in West Africa. With those resources, we put together a complex tech transfer to the Serum Institute of India, which ultimately produced a very affordable vaccine, which has now been rolled out across the meningitis belt to huge public health impact. It took us 9 years to develop, to do that tech transfer, do the testing, and get the vaccine registered. In there, the patent was a US government patent that we licensed in a non-exclusive way at PATH and subsequently sub-licensed to the Serum Institute of India. Literally anyone in the world could have licensed that patent. They didn't, because that wasn't, in that case, the critical element. What was critical were the ingredients. For the first several years, the polysaccharide ingredient of that vaccine had to be made by a contract manufacturer in the Netherlands until the Serum Institute could produce that ingredient itself. And ultimately, it was the conjugation chemistry and the exchange. We facilitated bringing Serum Institute of India scientists to the FDA in the United States and sending people from Rockville to Pune. That's what we need, is that tech transfer. Now, sometimes there's a patent that's an obstacle and needs to be resolved. And sometimes, and there are mechanisms for that. There are patent pools and other things for critical intellectual property to help solve that problem when patents are the problem. But they're often not the problem. And I think particularly in COVID-19, we're beginning to see lots of these technology transfer efforts, right? It's the AstraZeneca, Serum Institute work, their work with the Korean company as well, other tech transfers that are happening in Brazil and in South Africa, et cetera. And so that's not to say that patents aren't sometimes the problem, sometimes they are the obstacle. But often it's this know-how, the unpatented trade secrets of a company that need to be shared. And often the Gates Foundation has worked to broker those kind of tech transfer agreements so that we're, again, have the end in mind, a sufficient quality of affordable, high quality vaccine to address the needs of the world, particularly the low and income, middle income countries that are often left out of it when there are scarcity. Over.
I think that certainly there's been, at least in my view, a lot more momentum around tech transfer and production expansion, which is very encouraging. I think that's something that many countries, developing countries in particular, have clearly expressed a desire for us to not rely on imports that might be blocked at any moment. So I think that's certainly an encouraging note. I wanted to go back to what you were saying about the meningitis vaccine project, because I do think that raises a very interesting line of discussion that is happening in many places, including at the WHO Fair Pricing Forum that's happening this week, including in a recent press coverage of a project that the Gates Foundation has been financing based out of the University of Texas at Austin, which is, you could say, kind of a second generation or an alternate way of developing a vaccine that partners PATH, and I promised you I would come back to PATH, with University of Texas, with clinical trials happening in 4 middle income countries: Brazil, Mexico, Thailand, Vietnam, and also with Mount Sinai Hospital in New York. A very interesting partnership that is trying to develop a COVID-19 vaccine based on the same spike protein technology that undergirds, for example, the Moderna, I believe the Pfizer-BioNTech vaccines, but can be manufactured in chicken eggs, and therefore can be manufactured without perhaps the heavy kind of tech transfer, some of the infrastructure that might be needed to produce other vaccines. And to me, what's quite fascinating about this project is that it really does build in from the very beginning the production. Tries to build in affordability, tries to build in access in countries that have production capacity without relying on, having to freeze a vaccine at negative whatever degrees, as we've seen. I guess my question for you is, was that kind of alternative approach to developing a vaccine that the world could scale up and get access to at hopefully an affordable price? I think we don't know the price yet, but is that kind of alternative approach to research and development feasible early on, or did that have to be, in your view, kind of a second wave, second generation effort after the big firms had kind of won that initial race, so to speak? I mean, today we only have, well, many, but really a handful of vaccines that are available. Could different approaches have also been launched a year ago, or different ways of developing vaccines, I guess?
Yeah, so, we were very happy to be engaged with, the investigators in Texas, because I think it is a great innovation. If you read the story that was recently in the New York Times, they developed a way originally by putting two proline groups in to stabilize the prefusion protein, the spike protein, and make it more useful in terms of, and it's been used in now a number of, that 2P version has been used in a variety of vaccines. And as is often in the case in science, I think it was well described in the New York Times, once having gotten that success, the investigators turned to trying to make it an even better success. So they've now developed the hexapro antigen, where you have 6 of these proline groups that create an even more stable vaccine or target, that could be a component of a vaccine. And because, through our global access agreements, they're making that widely available to a variety of vaccine partners. So in some ways, it's a second generation because it's an improvement on the first generation, which is currently in some of the more effective vaccines already. So I think so one is to think about that antigen. And then the second is to think about the production of that antigen in eggs. And eggs, as we see from the seasonal flu vaccine, eggs have the advantage of low cost, et cetera. You could potentially, as the article pointed out, make that vaccine in different places. Eggs are also fragile, right? So we've had if you look at the history of flu vaccine production, sometimes the eggs, there's not enough eggs there, and they have to be, I remember once 15 years ago, there was a truck accident where a bunch of eggs were destroyed and it cut production of a flu vaccine. So, that's a promising way of using that new antigen. There are others. I mean, so what I would hope is that new antigen innovation actually gets applied in a variety of different vaccine production efforts. And one of the advantages of that might be local production in different environments, like they're looking at in Vietnam, et cetera. So, it's an exciting innovation, and the kind of thing that you have to. I remember back to the meningitis vaccine project, with the goal of producing a vaccine that was affordable for the meningitis belt. This was 20 years ago. It was in the earliest days of Gavi. We couldn't know for sure that there'd be, what Gavi grew up to be, if it were there 20 years ago, would have been more reassuring. But we had to look at various different ways. We initially looked at 4 or 5 different ways of making that vaccine. Finally, decided on working with the tech transfer of the Serum Institute of India because it was the most likely to succeed, meet regulatory hurdles, and be able to produce a high quality vaccine at a highly affordable price for some of the poorest countries in the world. So, in the end, there's a choice about how do you take the cutting edge of science, like the Hexapro work, and put it into a system that will get you volume, quality, and affordability. Over.
At speed. I promised the audience that we'd reserve 20 minutes for Q&A, so I want to turn to the chat in just a moment, but I'm going to abuse my privilege and squeeze in very quickly one last question, because I do have to ask about WHO funding. And I think that last year, in a nutshell, we all remember when President Trump said we're leaving and we're taking our money with us, which would have left a 16, 17% hole in WHO's budget. If they had done that, the Gates Foundation would have been the single largest funder of the WHO. And I think nobody wishes that money would totally disappear, in the sense that WHO needs 10% of its budget that is covered by the foundation. At the same time, it does raise this fundamental question about what is an appropriate role for a public versus a private actor. And what's your take on that? I mean, what do you see as the appropriate degree to which the foundation should be funding WHO, should influence priorities, if at all? How do you think about this?
So thanks, Suri. I mean, I'll make a couple of brief comments so that we can get to the chat. I think the COVID-19 pandemic has brought into focus a fundamental vulnerability in the global health architecture. The fact that the World Health Organization receives about 23% of its support from its member states, and therefore has to receive over 3/4 of its support from voluntary contributions, is a huge vulnerability. I mean, I attend the World Health Assembly most years, and each year the member states give the WHO more mandate, more to do. And yet they've had effectively a flat budget for the last 20 years. That's not how we should run the global health architecture. If ideally the member states of WHO would finance WHO and they wouldn't need the Bill and Melinda Gates Foundation's resources. Over the years, because there's often been, concerns and criticisms related to our influence of WHO. I think what's important to realize is that the WHO has a global program of work that's decided upon by its member states. We have strategies that are developed and vetted with our governing, board with Bill, Melinda, and Warren Buffett. And then where there are areas of overlap, and there are many, right? Polio eradication, immunization in general, nutrition, support for good quality medicines regulation, et cetera, we support those areas of the global program of work that are aligned with our strategies. And that has added up over the years to, I think we have over 100 active grants to the Gates Foundation now, all of them voluntary contributions. And it's added up to us being the second largest funder of WHO. I once was challenged by a member state who said we had too much influence, and I gave him the list of all of our grants and said if he could find one that wasn't in the global program of work that they had endorsed, I would cancel the grant. And they didn't come back to me. Right? So we're generally aligning our support. That does mean that some parts of WHO are better supported than others because we don't have a strategy for everything in global health. Again, back to my original point, this is a vulnerability that the governing body of WHO needs to address. Now, they're not going to be able to quadruple their assessed contributions overnight, but I think they need to think through, in my view, a pathway to more secure funding of the organization, some progressive realization over time of increases in assessed contributions. If this pandemic doesn't show the vulnerability of not having that, I'm not sure what will. Over.
Indeed. Let me turn now to the many questions that have begun to come in on the chat, and I promised I'll try to do rapid fire back and forth to get through as many as we can. I'm going to combine the first couple that have come in, and we have a question from an anonymous attendee actually about what are the accountability channels for the Gates Foundation or accountability mechanisms, and what do you mean by civil society engagement? This question comes from Cornelia Albert, and I hope I don't badly mispronounce too many people's names. I think these are related in a way. So overall, channels for accountability, and would you say a bit more about how you engage with civil society?
Sure. So, our accountability, so we're a private philanthropy in the United States. There are a complex set of regulatory rules that govern nonprofit organizations, including private foundations in the United States, and we pay very careful attention to them and comply with them. You can go on the web and read our 990 reports, et cetera. Our board is Bill and Melinda Gates and Warren Buffett are the trustees of the foundation, and we have regular sessions with them to approve our strategies, approve the budgets associated with those strategies, and then delegations of authority to the executives and the directors of the foundation to execute on those strategies. Our accountability, though, if you think of, so that's the governance and strict accountability. If you think about our accountability, though, it's really to be part of a global discussion about health and development that requires us to listen carefully. Sessions like this, our interactions with the private sector, with civil society, with the UN, with academia, et cetera. Because to be effective, there's very little we do directly ourselves. Much of it is done through partnerships, through grants, through innovative financing mechanisms. So we have to be part of the discussion to hear the feedback about how we could improve the use of our philanthropic resources, including our voice as a foundation, for advancing global health equity. Civil society in particular has been a very important component of that. Many of our grantees are in civil society, and through our partnerships with them, provide us lots of feedback. We do encourage generally in the large partnerships that we're part of, like Gavi and the Global Fund, that there be defined mechanisms for getting civil society input into those agendas. And, as I said, with ACT A, we, I think, have made an effort, have not made sufficient effort. I think we're going to have to strengthen that as we, go forward with that coordination mechanism. So, we do periodic, discussions and surveys with our grantee community to get feedback. So it's not the strict accountability that would come from a governance mechanism, but it is important to us because it's how we have our impact. I mean, in our executive team, we think, our motto is, impact first, right? How do we deploy these resources for impact? That's the key thing. Oh.
Thanks very much. There's a number of questions coming in around the TRIPS waiver that's being debated at the World Trade Organization. I'm going to try to consolidate them. I think there are a number of questions, of course, on what you think about that waiver, but also what can or has the foundation done to influence governments and the way governments are thinking about their position on this waiver. And, we read in the newspaper about how Bill Gates can pick up the phone and call Bono and Angela Merkel and Emmanuel Macron and Nancy Pelosi, and, the list can go on and on, has the ear of world leaders. Is there an influence that can be brought to bear, that is brought to bear on questions like the TRIPS waiver?
Yeah, so, I think that in general, those are, discussions that happen within the governing body of WTO, which we're not a member of. So I'm not aware that we've used our voice to try and influence people's position on that. I think we've been very focused on what's it going to take in the short term. This goes back to my discussion around how we think about intellectual property. If, and I haven't studied it carefully enough to, I think that, we've been trying to influence how do we get more supply right now for vaccines, and leveraging the capabilities that are currently out there. If there's a strong case for, and I think it could be debated whether waiving TRIPS is going to get you there faster. So I think we really want to focus on what can we do now to secure as much supply through the advanced market commitment at COVAX for vaccines for low and middle income countries. And how can we help COVAX make sure they have enough money to actually be able to purchase and deliver that supply? So we haven't been very involved either way in the TRIPS waiver debate today. Over.
There are a number of questions indeed about precisely this question: the volume of vaccines for COVAX, the role of technology transfer. And again, I'm going to try to condense a few of the questions that have come in. What is the role the foundation has played or can play to try to persuade more technology holders, in fact, to transfer that technology, whether it's companies or other technology holders? Should that have been a more central part of COVAX's strategy early on? Why such a heavy reliance, for example, on the Serum Institute in light of the export restrictions that the Indian government is putting in place? Was there an alternative to that?
Well, I think there are, so just a word, because I've worked with the Serum Institute for many years. They are the largest producer of high quality, low cost vaccines for Gavi, for many vaccines. I think they are, the single largest producer, for instance, of measles vaccine for the developing world. So the Serum Institute of India was a logical partner, right? It's been a critical component, a critical partner for many of the tech transfers, the meningitis vaccine project, a rotavirus vaccine, a pneumococcal vaccine. They were a logical partner to participate in tech transfers, and I think AstraZeneca and Novavax have engaged in those discussions. I think many of the multinational partners have been pursuing a range of tech transfer efforts. Our focus has been more, I mentioned we've committed $750 million out of our strategic investment fund. The largest of those commitments has been in forgivable loans to Gavi through COVAX, through Gavi, to help incentivize and secure the scaled manufacturing of those vaccines from the Serum Institute of India. We are in discussions with other companies until they're finalized. I can't really talk about the details of them. So we are actually supporting a range of different tech transfer efforts. Gavi was able to move quickly with the Serum Institute, partly because it is such a large scale and well-established partner of COVAX, but it's not exclusive in any regard. And we will be working, are working on other tech transfer agreements that are just not ready to be announced yet.
Okay, thank you. Maybe a couple of questions that we can squeeze in before our time runs out. The first, just to change tack a little bit, we change themes. There are a couple of questions that have come in about the situation in Venezuela and in Brazil. And I think questions around, are there things that a big powerful player like the Gates Foundation can do with governments that might not be adequately meeting the needs of their own people? And I think this does touch on the broader theme of public and private roles and responsibilities. Is that something, for example, getting on the phone and trying to persuade a president who is not perhaps putting in place all the measures needed to control the pandemic? Is that something that you consider to be within your?
Yeah, so we try to be nonpartisan in all of our efforts, both with high-income countries and with middle and low-income countries. Again, kind of trying to think about the goal, right, which is to help ensure that people have the chance at a healthy and productive life. Governments, often our role is in trying to work through these multilateral partnerships, through the UN system, through WHO, which has a regular and structured dialogue with many of those governments, where we are working to help produce low cost, high quality innovations that can move through those partnerships, like the Global Fund, like Gavi, through the WHO and UNICEF, to reach the people in need in those countries. So generally we work through those structures. In some of the places where we have more presence, we do have offices in India, South Africa, Ethiopia, Nigeria, as well as Beijing. So in those places, we have more regular dialogue with countries where we actually have a presence in the country and more established country relationships. But we're not really well positioned to work in every country, in a dialogue with every country, like organizations like WHO, UNICEF, and for the lower middle income countries, Gavi and the Global Fund can have. And we're major supporters of each of those institutions and have, but they're generally in the lead in some of those discussions.
There's a few questions coming in, again, focusing on ACTE. And again, I'll try to condense them by theme. With some of the current discussions turning to how ACTE might be institutionalized or reformed, or maybe we could call it an ACTE 2.0 in the future. What do you think ought to be the role of governments? What is the appropriate role of governments in something like ACTE, as amorphous as it might be or might have been? And related to that, looking back and considering, I think all of us have been surprised and learned many things and have constantly had to adapt throughout the course of this pandemic. Is there anything that you would change about the strategy of ACTE with the benefit of 2020 hindsight?
So I think we're still learning about ACTE. So I think, personally, I think it would be premature to decide whether we should institutionalize it or not. I think we have to look at what's worked, what hasn't worked, what could be improved. Just a note, because I did mention it at the beginning, governments are involved in ACT-A through what's called the Facilitation Council, which is co-chaired by the governments of Norway and South Africa, and where the majority of the participants in the Facilitation Council, which is sort of the very high level coordinating body for ACT-A, most of those participants are governments. There are civil society representatives, philanthropic representatives on that facilitation council, but my guess is that 80% of it is governments. So governments do have a voice in ACT-A. I think we need to understand, the original intent was to not build a new institution, to have a time-limited coordination mechanism. Now, I think what we're learning through COVID-19 is that the world was unprepared. You mentioned at the beginning, I participate on the Global Preparedness Monitoring Board. We put out a report in September 2019, so 5 months before the pandemic, where we had a whole chapter saying that, while we had made incremental improvements in preparedness for emergent infections like Ebola, that we were still very woefully unprepared for a fast-moving respiratory pathogen. 5 months later, we looked like we were prescient. I wish we hadn't been. But we were just stating the reality that the world didn't have in place the financing, rapid response, coordinating mechanism. So there are currently quite a few assessments going on within the Independent Panel for Pandemic Preparedness and Response, the WHO's commission, through the GPMB, through other commissions, to understand what the world might need as a better preparedness coordinating structure going forward. I think the lessons from ACT-A should feed into that. And then we should decide, do we build on the ACT-A coordination? Do we build a coordinating structure that takes the lessons of ACT-A, good and bad? I see in the chat, there's also discussions about, a pandemic treaty that 25 heads of state have called for. That's a very important discussion to focus on what would a treaty serve, what would be the key things where you need binding legal agreements between countries. That's all under discussion. As the Global Preparedness Monitoring Board, we've actually been studying. We've had presentations to our group on the Sendai framework for disaster preparedness, a review of the pandemic influenza partnership, the framework convention on tobacco control. There's a lot to learn from in how the world has approached other critical issues. So I would say that discussion is in flight, and it would be premature to say today, no, we shouldn't institutionalize, or yes, we should institutionalize ACT-A. What I think we can definitely do is learn from what's worked and what hasn't worked as well in that coordination over the last year.
I'm going to try to squeeze in one last one, which is, given the work that you were just alluding to regarding ongoing efforts to increase tech transfer, would the Gates Foundation share technology through the WHO CTAP initiative? It's been written in the press that the foundation is not in favor of that technology pool, the technology access pool. What's your take on this particular initiative?
I see CTAP as an important mechanism. If it's kind of matching solutions for problems, right? So I think it's not correct to say that we're not in favor of it. I think it's a useful mechanism. Back to what I said about intellectual property, if patents are the issue, that may be one of the ways to solve it. I think in our experience today, patents haven't been so much the problem here. Now, historically, patents were a huge problem in the antiretroviral drug access debate 20 years ago. When we didn't have things like the Global Fund, we didn't have the kind of experience of using tech transfer to get out more generic, low-cost medicine. So, I think we're again, to what I said before, it's not that, I don't want to say patents are never the problem, but I think the bigger problem in vaccines in particular is how do we get as many of these tech transfers so that we can get high quality, low cost vaccine at scale as soon as possible. If a patent proved to be the obstacle, CTAP or some other mechanism for pooling patents could be part of the solution. It's just that as we've been working with the vaccine companies now, it's the challenge seems to be more about the tech transfer, the rapid scale, the capacity for producing vaccines. We've never tried to produce this many vaccines at this level, this fast. I mean, I think it's worth taking a step back and saying, wow, what a year. Science has really over-delivered here, right? And, we have a number of vaccines that are under EUL already, and that's never happened. I think the fastest we ever did it before was to make a mumps vaccine in 4 years. The meningitis project I talked about took 9 years. So, amazing what science has accomplished in the last year. And with that, the effort to get manufacturing at scale and to build more manufacturing capacity, that's a different kind of problem that's not going to be solved by CTAP. So we're not opposed to CTAP. And if a patent is the problem for any of these technologies, I would include therapeutics and diagnostics as well, then that could be a part of the solution. It's just not, in our experience, been the solution we need at this moment. Over.
Thanks so much, Chris, for spending this hour with us. I think it's been hugely informative, a really terrific opportunity for me and for the broader health community to be able to engage in this dialogue with you. I wanted to thank all of our audience members for the terrific questions. I'm sorry we couldn't get to every last one, but I hope we hit all of the major themes. Indeed, I think you summarized it really nicely. What a year, and it's not over yet. So I hope in 1 year's time we can have another conversation like this and look back at all of the big steps forward that were made in 2021. But until then, lots of work to be done. So thank you again. Thank you to my colleagues here at the Global Health Center, especially to Elisa Codato and Dishwan, both of whom have been working very hard behind the scenes to bring this event to you. I just wanted to flag that our next event is next Thursday, April 22nd, where we'll be hearing from a wide range of speakers on whether global health is in disarray, what comes next. So it's a chance to really explore some big blue sky, pie in the sky thinking about where are we heading in global health. Please join us. Thank you again to Chris. Thanks to all of you, and signing off from Geneva.
All right, thanks, Suri. Thanks, everyone. Thanks for joining us today.